Hello, everybody. Thank you very much. All right, tonight's program is sponsored by Genentech, Novartis, Sanofi, and TG Therapeutics. Dr. Emily Reiser has been a well-known MS neurologist in the Alabama and southeastern probably region area for a very long time. She's with the Tanner MS Center here in Birmingham. And, I can't wait to hear her give her presentation. It's been a number of years since I've heard Dr. Reiser speak, and I can't wait to hear her again. Thank you.
Thank you, Stuart. Let's give a round of applause for Stu for coming to Alabama. Roll Tide and War Eagle, right? Thank you so much. It's a pleasure to be here. We love working with MS Views and News. It's always just been such an incredible event. He goes all around the country, and we're lucky that he has chosen Alabama to be part of his network. And Tracy, congratulations. Great job. We really love that. So tonight I'm going to kind of feed off of what Tracy has chatted about relative to aging. I've got a few objectives for about what we're going to talk about, but then I'm going to kind of segue into some other topics that Stu asked me to chat about, including high efficacy therapies and some other things. But these are our objectives. We're going to basically review the pathology of MS because some of you may be newly diagnosed. Some of you may have not been to programs since COVID, and it doesn't hurt just to review a bit. We're going to discuss the 2024 revisions of the McDonald's criteria, and that's basically the criteria which allows the neurologist and the patient to determine if they truly have this condition. And there's been a lot of brouhaha about that I think you need to know. We're going to review new biomarkers, including MRI biomarkers and serum biomarkers. I think biomarkers are a real hot topic in MS right now because I think a question came up, how do you know whether something's age-related or MS-related? Well, we may now have tools in our toolbox to help us to know that. We're going to look at current phase 3 research trials. We're not going through everything on www.clinicaltrials.gov, but I'm just going to hone in on the ones that I think are hot topics currently. And then finally, we're going to chat about immunosenescence. It's a really big word. And we're going to talk about that relative to aging and how that affects individuals living with multiple sclerosis. So this is that brief overview of multiple sclerosis that I just wanted to chat about. When people think about MS, they think about this being a disease of the central nervous system, the brain, the spinal cord, and the optic pathways. But this condition really starts out in the periphery. This condition starts with dysfunction of the autoimmune system. The immune system is given to us at birth, very naive, but through antigenic stimulation and exposure to germs and pathogens over the course of our life, we develop immunity. But what happens in multiple sclerosis is that the switch is flipped, and suddenly the immunity becomes in overdrive. And then this inflammation that occurs peripherally migrates across the blood-brain barrier, which would be this guy right here. So here's the peripheral response, but once these cells migrate across the blood-brain barrier, then these immune cells, they begin to attack the insulation on the axon, and the insulation is called myelin, hence the name demyelination. So this starts peripherally. Once this starts peripherally, then the action is inside. So this is an outside-inside condition. And once this gets inside, then all of these inflammatory cells begin to wreak havoc on the neural network, the axon, and then the demyelination, which comes as a secondary downstream effect of this. So I just want to call out a couple of cells and just remember these cells, because as we talk about new novel treatments, I'm going to be talking about these things and naming these things. One is something called a microglial cell. A microglial cell is a scavenger. In the periphery, we call it a macrophage. In the central nervous system, we call it a microglial cell, this guy in purple. This guy in purple is causing trouble. We didn't know about him a long time ago, but this guy is really cruising around in the central nervous system, taking up debris and causing a lot of secondary downstream problems. This guy right here is a B cell. A B cell, we thought, had one function, and that was just to make antibodies. Take a jab, like a COVID shot, you make an antibody. Well, antibodies are great, but if antibodies are not behaving the way they're supposed to behave, they can wreak havoc in the central nervous system. But the B cell also is in close conversation with a T cell. And a T cell would be these guys right here, these Th17s, there's some other ones. But just remember, microglial cells, scavenger cell, B cell, the cell that makes antibodies and also crosstalks with the T cell, and then the T cell itself, which can cause downstream effects by releasing things called cytokines. So the update here for tonight is that, and there are many of you in the back corner, you guys, I've been with you guys for a long time in pharma. We used to just think that this was a T cell mediated disease, but really that's not the case. I think the B cell really is gaining a lot of interest in the scientific space because, we know that it crosstalks with these T cells and causes downstream inflammation. We also know that B cells can actually set up residence in the central nervous system. We know that B cells can live in like pseudo-lymphoid tissue inside of our meninges, and it then becomes the gift that keeps on giving. And finally, we know that these microglial cells are probably what's contributing to this chronic smoldering MS. And I get a lot of people asking me about this, but I think it boils down to the fact that once this inflammatory response is set up inside, it's really hard to make it go away. So what happens from a cartoon perspective, on the left, you have a normal axon covered by beautiful myelin, and on the right, you have a dysmyelinated or denuded axon with scarring. And the scars, if there are multiple scarrings of the nervous system, we call it multiple sclerosis. So that's basically how this condition got its name. It got its name from the fact that there are many scars down deep in the white matter, and now we know even in the gray matter of the central nervous system. This is an MRI scan. How many of you have been in an MRI scan? Okay, makes a lot of noise. It's a little bit claustrophobic up in there. We really want you to go into the high field MRI scan to get the best sequences and the best study. But what we know now is we can use MRI as a biomarker to prove if someone has MS or not. We didn't have this in the 80s. We didn't get this really until the late 80s. But this is a classic or typical MS plaque / scar. It's going to have a classic appearance. It's going to be kind of periventricular. It's going to be ovoid. It's going to be in a certain area in the brain. And when you give contrast, when they roll up your sleeve, put the IV in, and give you the dye, it can light up like a little Christmas tree. And that's what we would call an active lesion or a gadolinium-enhancing lesion. So a basic MS plaque, an active plaque, a baseline MRI scan, a scan years down the road with increasing numbers of T2 white, bright lesions, i.e. multiple sclerosis. So the natural history of MS is interesting because we used to just say, well, there's relapsing remitting MS, but now we know that MS can really occur way before one is diagnosed in this kind of preclinical phase. And there's been studies where they've gone back, the scientists, and even Tracy looking at hospital data, where they see where individuals who were ultimately diagnosed with MS were showing up at urgent care centers with UTIs, with spells, with weakness, with all kinds of things before they actually ended up in clinics where they were definitely diagnosed with MS. So there's this preclinical phase, then the obvious first event, the clinically isolated syndrome, the relapsing forms of MS, then active secondary progressive MS, non-relapsing MS, and so on and so forth. But I want to draw your attention to the red line. The red line is the question that I get asked about every day in clinic. Is my MS getting worse, or am I just getting old? So we're going to chat a little bit about this. I think Tracy's laid the groundwork for it, but that's the hot topic right now. So what does MS do? Well, I would say the lion's share of clients that I see who are living with MS tell me that they suffer from fatigue. And you would say, well, I'm just tired. I just don't want to go to work today. What is this? Well, this fatigue is quite different. This fatigue is probably the biologic effect of the inflammation inside the central nervous system. It's more than just being tired. It's being incapacitated, quite frankly. And I would say more people go out on disability due to the fact that they just cannot function secondary to fatigue. So how do you manage and mitigate fatigue? Well, we don't have an FDA-approved therapy for this yet. I know some of the rehabilitation strategies that they work on at NICPAD have been useful. From a therapeutic perspective, we use some off-label therapies, treatments, stimulants, narcolepsy medicines, and things such as that. The other big symptom that's kind of a silent, not so commonly talked about symptom is cognitive impairment. I think it's a very problematic issue, not only for the individual living with MS, but for the family and the loved ones who are trying to support the individual who suffers from cognitive impairment. This is not like anything like Alzheimer's. This is very unique. It's a dysfunction of short-term memory, speed of processing, and retrieval. So it translates into not being able to multitask. That is the big problem here. So how to treat it? I would suggest getting in with a cognitive rehabilitation specialist. Sometimes we can use off-label medications that we use for memory loss and other disease states. Sometimes we can use those as well. But a lot of the things that that Tracy was talking about, dual tasking, all these kinds of things can be very translational in helping individuals who suffer from cognitive impairment. Bladder dysfunction, it's so annoying. It needs to be addressed early in the course of the condition. This condition can either be a sense of urgency or it can be something that we call retention. We recommend that you bring a urologist onto the team and have a urological evaluation as part of the workup for multiple sclerosis. And there's many, many things here on the slide, and I think Tracy already spoke to the walking and all of the issues related to that. So the new updated 2024 McDonald's criteria, diagnostic criteria, they have everything to do with what they've always had to do with, which is dissemination is the word, and it's dissemination in time and in space. So in the old days, we had a black bag and we just carried it around and we walked around and we would see people in the clinic and we would say, well, tell me about what happened. They said, well, I was blind in my left eye. Okay, and then what happened? Well, then I was weak in my right leg. Well, that would be clinical diagnosis of MS and the exclusion of everything else because it happened at 2 time points and it happened in 2 different spaces. Time and space. Well, fast forward to where we are now. I just showed you a picture of an MRI. Now we have MRI as a biomarker. So if someone comes into the clinic and they've had loss of vision in the left eye, we can do an MRI scan and we can prove 2 of 5 locations that we are assessing on the MRI. If the client has 2 lesions in these spaces, 2 out of 5 spaces, so if there are lesions in 2 out of 5 spaces, that suffices for spatial dissemination. So 1 optic neuritis, blindness in 1 eye, if someone has an MRI and there are lesions in 2 of these 5 spaces, there's spatial dissemination. And the time dissemination can be made if someone has an active lesion on the brain. So time can be fulfilled by the gadolinium lesion on the brain, and time can also be fulfilled by a spinal tap if there are these proteins called oligoclonal bands and or kappa light chains. So the exciting part for me and for individuals who are coming into the clinic is that we can diagnose MS very early. And that is the time where we can then apply therapeutic treatments that are going to be translational for preventing disability and further changes on the MRI. So that's the latest update on McDonald's criteria. And in the McDonald's criteria, not only are there these 5 locations where these lesions happen to be, but there's this new biomarker called a central vein sign. We know that the pathology of MS that I showed you on the early slide that's inside, it's occurring around a little vein. It's perivenular. It's around a little vein. And when you look at MRIs, you see the little vein and you see the inflammation around it. So this is now like a really hot topic in multiple sclerosis. If someone comes in with loss of vision in the eye, we're seeing these central vein signs. There's gadolinium enhancement or perhaps the oligoclonal bands. We can say with impunity that this is definitely MS, that this is not a mimicker or anything else. So it's very exciting to know that this is a new biomarker. So here we are. People used to say, what kind of MS do I have? Well, look at all of this. We have radiographic isolated syndrome. We have clinically isolated syndrome. We have relapsing forms of multiple sclerosis. We have active secondary progressive multiple sclerosis. We have non-relapsing secondary progressive multiple sclerosis. And we have primary progressive multiple sclerosis. So it's really become very nuanced. And I think it's exciting here in Alabama. We're fortunate to have 4 MS centers in Alabama, where the people there really understand all of this. And that's in Coleman, 2 in Birmingham, and 1 in Mobile. We're very blessed to be in Alabama and have all these centers that focus on all of this. So you're blessed to be where you are, and you got a good squad of people taking care of you. But this is where we are. So current and future targets for treating MS. I talked to you about the microglial cell, the scavenger. I talked about the role of the B cell. I talked about the T cell, which we kind of thought used to be the root cause of MS. But now we know that, there's things that we can do strategically to really get MS under control. And that's our goal, is to really get after it early on. So 1, we can sequester those lymphocytes in our lymphoid tissue. Remember, I told you it starts peripherally. If you can keep all those cells in the peripheral system locked up in the lymphoid tissue, and they're not allowed to go out in the bloodstream and cross the blood-brain barrier and get into the brain, you've accomplished something. Or you could give a treatment that prevents the lymphocytes, the immune cells, from going across the blood-brain barrier. So they're wandering around in the periphery. They want to get in here and wreak havoc. You can give treatments to stop or block the transmission across the blood-brain barrier. These particular treatments are called, I put S1P antagonists because we have so many of them now. The mother drug was Gilenya. There's several iterations of that. But the main drug for trafficking across the blood-brain barrier is Tysabri. I'm sure many of you know about Tysabri, a very effective drug. The second thing is we can deplete immature B cells. So we can just say, we know this B cell is a culprit. We know it's causing problems, very premature ones coming out of the bone marrow. And we can give treatments to eradicate those really angry birds, those angry B cell birds that are causing all of this. And we can do this by using these things called monoclonal antibodies. And I put Ocrevus, Kesimpta, Briumvi, but there's Zenovo too, but a new one with Genentech, which is sub-Q Ocrevus ostensibly, but it's going to be, ocrelizumab, ofatumumab, and ublituximab. So we have anti-CD20 monoclonal antibodies. I'll show you what a monoclonal antibody is. These are therapies that can be infused or they can be given subcutaneously, highly effective in keeping MS under control. So that's the second thing we can do. The third thing we can do, we can actually modulate the way that B cells behave, and we can modulate the way that a microglial cell behaves. So we can do a 1-2 outside, inside punch to get after this. And this is done using a CNS penetrant molecule called a Bruton and tyrosine kinase inhibitor. So the language of what y'all could take away from here is BTKI. So that's a big story right now. It's called a Brutanin. It was named after Dr. Brutanin, who was a pediatrician who discovered pediatric immune deficiency. So they looked at some of his work, the scientists did, and they said, well, you know what? We can actually model some of what he did. And if we can take a small molecule, we can actually give it in an oral form. We can deplete B cells peripherally, and since it crosses the blood-brain barrier, it can also modulate the effect of the microglial cell, and it may therefore have some really important effect on preventing progression. So it's a very exciting topic. And finally, we can just flat out deplete B cells and T cells. We've been doing it a long time with monoclonal antibodies, one called an anti-CD52, which is Lemtrada. We have a novel product, a monoclonal in phase 3. It's called frexalimab. It's being studied for relapsing forms of MS. It's also being studied for non-relapsing secondary progressive MS. So it's a new monoclonal antibody working on CD40. And then we have chemotherapy. And I'm here to tell you, after 40 years of practicing neurology, starting down at UAB in 1985, we used to use chemotherapy to treat MS. We don't do that anymore, except for this compound called Mavenclad, but we don't use the real harsh chemotherapy that we used to use. So what is a monoclonal antibody? A monoclonal antibody is anything that ends in mab. Natalizumab, ocrelizumab, ofatumumab, ublituximab, alemtuzumab, mab. So how did the scientists figure this out? Well, the beautiful thing, and we don't have any of our researchers in the room tonight, but Tracy and I know a lot of these people. They live and breathe all things rats and mice, and they're in their lab every day with their sleeves rolled up working on these discoveries. And what they figured out is they could take a mouse model, and they could inject an antigen into the mouse and train the mouse to create antibodies and mix it with some myeloma cells, create a hybridoma, and this will give us a bounty of monoclonal antibodies. So whether that's Tysabri, whether that's Ocrevus, whether that's Kesimpta, whether that's frexalimab, the scientists can use this mouse model to create these monoclonal antibodies to do all of these specific things. So it's really quite extraordinary. So this is an immune cell right here. Okay, this big fat guy in the middle. And this immune cell has many things on its surface. CD19, there's actually a drug for anti-CD19 that we use to treat NMOSD. CD20, I've told you about a plethora of those that we use to treat MS. CD40, one in clinical trial, phase 3 for relapsing MS and non-progressive secondary progressive MS. CD52, for multiple sclerosis, already FDA approved. And so it goes on here, blocking trafficking. So science has brought us all of these amazing high efficacy therapies because they know about this, and they can go into the lab with the mice and create these models to give us these monoclonal antibodies. So you would ask me, Emily, what is a Bruton and tyrosine kinase inhibitor? Well, I told you Dr. Bruton discovered immune deficiency in children, and he discovered that they lacked an enzyme called Bruton and tyrosine kinase. Well, BTKI is something that blocks that enzyme. So this enzyme is very important for activation of B cells and very important for activation of microglial cells. So if we know that the microglia and the B cells have to have this enzyme to be activated, and that's not good, that's bad in MS, then we can give a small molecule to block that. And if you block that, then you would subsequently decrease B cells and decrease the activation of microglial cells. So it's an outside-inside effect. And these are oral medications being studied in clinical trial right now, although there's one that's going to be fast-tracked pretty quickly, and I'll tell you a little bit about it. So here are the names of these guys. There's a bunch of them. The ones evobrutinib, tolebrutinib, fenebrutinib. Some of these so far in clinical trial have not been totally evidence-based effective in relapsing MS, but there's one right here called tolebrutinib. They all end in NIB. Monoclonal antibodies end in MAB. These end in NIB, NIB. Tolebrutinib is a brutinin tyrosine kinase that was recently shown to be effective in non-relapsing secondary progressive MS in a paper published right here in the New England Journal of Medicine, April the 8th of this year, hot off the press. And it delayed the time of onset to 6-month confirmed disability progression by 31%. This is huge. We've never had a treatment for people living with MS who have this form of non-relapsing secondary progressive MS. So this is our first BTKI that the FDA has designated to be on a fast track. So we may be seeing something later this year on that. So what is our goal of these high efficacy therapies? What are we trying to achieve here? We're trying to get to this concept of NEDA, no evidence of disease activity, and we're trying to do it in a way that we can ensure that there's no relapses, no progression of disability, no changes on the MRI that I just showed you, and no cognitive changes. So these are all the things that we're trying to achieve. But remember I talked to you about the red line. So we have not achieved 100% NEDA in everyone living with MS, but this is certainly our goal. So how do we achieve NEDA, and how can we better manage and monitor people living with MS to ensure their best success? And the way we can do this is we can use these things, tools, metrics that we call biomarkers. I've already shown you a couple of them. An MRI is a biomarker. A central vein sign is a biomarker. But we have all kinds of biomarkers. We have monitoring biomarkers. Like if you're on a drug and you come to see your neurologist, we check your labs to make sure you're okay and safe. We have diagnostic biomarkers. We have things now that, we can look at that tell us, yes, this is MS. We have susceptibility risk biomarkers. For example, if you're taking Tysabri, we can check JCV. We can minimize the risk of PML. We have safety, predictive biomarkers. So the biomarker story is really going to be the secret sauce in helping folks with MS to achieve NEDA and to achieve success. Now, we already know in multiple sclerosis that these are validated diagnostic biomarkers. One, if someone comes in with optic neuritis and the MRI shows the 2 out of 5 spaces and there's oligoclonal bands in the spinal fluid, we know diagnostically that's MS. We also know that there are other things in the blood that can be tested that can kind of give us clues like, have you been exposed to Epstein-Barr virus? Do you have antibodies to MOG, which is another protein that's on myelin? We have disease activity biomarkers. We can now check these things that T cells are making called cytokines. We can tell exactly what all that's kind of up to, so to speak. We can now check biomarkers for disease progression. We can see if you have something in your blood called neurofilament light, which can predict disability going forward, kind of the red line. And then we have biomarkers that tell us if you're having a therapeutic effect to your medication. So a lot of cool stuff really going on. But the hot topic on biomarkers is this one, okay? Octave is a company in Menlo, California. These guys, these scientists and guys at and gals that think outside the box, they came up with this formula where they realized that there's 18 proteins that are in our bloodstream that have everything to do with inflammation, degeneration, MOG, or immunomodulation. So they followed a large cohort of patients in the United States and Europe, and they were able to cobble together numbers of relapses, changes on the MRI, looking at these proteins, and then using an algorithm from one of their biostatisticians, and Tracy will tell you we know nothing about biostats. But the biostatisticians are really smart people. They were able to take all of this data and these people that they were following prospectively with MS, with these 18 proteins. It's one little tube of blood that you draw. And they were able to come up with something called the Multiple Sclerosis Disease Activity Score. So now we have a way to draw a tube of your blood, and on an ordinal scale from 0 to 10, we can tell if you're stable or maybe if you're not so stable on the current treatment, or maybe if you're not taking a treatment. So this is pretty cool. And this is the test called the Octave MS Disease Activity Score, and it's now being used in a lot of the clinical trials that we're doing. Okay, so we can't have a program without talking about PIRA. So this is the red line that I was getting after. PIRA stands for progression, P, independent, I, of relapse, R, activity, A. Now, before I get into PIRA, say someone is 55 years old and they come in to see me in the clinic and they say, well, gosh, my balance is terrible. My thinking is terrible. I have so much more fatigue. Oh, my goodness. Is that aging? Or is this PIRA? Is this chronic smoldering MS? Is this a form of MS that despite our high efficacy therapies that we may not be treating completely, if that makes sense? So now we have biomarkers to show us if someone has chronic smoldering MS or this PIRA. And what it is, they're MRI findings. One is a cell, and the other is a pearl, not like a necklace, but a PRL. So we have a cell and we have a pearl. A cell is a slowly expanding lesion on the MRI. Here's someone who had an MRI with this lesion here, and after a year, it got bigger and it got darker. That's a cell. That's a slowly expanding lesion. That is a marker of PIRA. The second is a pearl, a paramagnetic rim lesion. This is a biomarker. So we can see this now. And this would give us a read on kind of chronic smoldering MS. And it has to do with deposition of iron and around an MS plaque. And you can see them. You'd have to blow it up, but they're right up here. They're little curvilinear kind of lesions around plaques. So cells and pearls. So we're moving into a new space. And finally, that leads me to immunosenescence and aging, because that's really been the focus of a lot of this discussion tonight. And I'm looking forward to the questions. Immunosenescence, y'all, is the natural aging process that affects the immune system. Tracy already told you people get osteoporosis, they get congestive heart failure, they get diabetes, they get polyarthritis. Well, the immune system gets old too. And when it gets old, and I'm not talking about old people, I'm talking about people over the age of 55, and that's starting to sound young to me. I got a birthday coming up. 55 is young. So immunosenescence is the natural aging of the immune system. And it can put an individual, a patient living with MS, at risk for pneumonia or a urinary tract infection, particularly if they're on a very high efficacy disease-modifying therapy, which is depleting B cells or modifying or modulating microglial activity or what have you. So there may be a conversation that needs to be had in older people. Should there be some de-escalation of their treatment? We're getting after MS early with these aggressive therapies, but then as someone ages and their immune system begins to age, should there be a conversation about pulling back a little bit? And then there's even another brouhaha developing about, is there a window at which disease-modifying therapies could be discontinued? There's some controversy, I think, in that discussion right now. But the feeling is if someone is 55, 60 years old, they've been 3 to 5 years without a relapse, they're on a disease-modifying therapy that's maybe one of the earlier disease-modifying therapies, not the high-efficacy therapies that we're talking about. Perhaps that might be in the conversation. But the only caveat from my perspective would be anybody that's taken one of those drugs that holds up the lymphocytes in the lymphoid tissue, or if they're on those medications that are preventing trafficking across the blood-brain barrier. We'd have to be real mindful about a sudden discontinuation of disease-modifying therapy in that cohort. But I think the conversation of de-escalation to a more moderate form of a treatment might be a conversation that your neurologist would have with you at that stage in your MS. And finally, I want to leave you with a new word, inflammaging. That's how you pronounce it, inflammaging. It's a real concept. This doesn't have anything to do necessarily with MS. This just has to do with people like me. So if you're over 65, so I've already told you my age, if you're over 65, what happens is that the innate immune system, we have 2 types of immunity. We have the adaptive immunity, which is the type of immunity that's involved in the pathogenesis of MS. But we have very basic innate immunity that we're born with. And as we age, our innate immune system becomes very overactive. It becomes inflamed, and it begins to secrete these pro-inflammatory cytokines, particularly IL-6 and tumor necrosis factor. These things can be measured, but we now believe that with inflammaging of the innate immune system, that this is really the crux or the biology behind, why people develop heart disease, diabetes, osteoporosis, polyarthritis, cancer, and all of these things, right? And obesity. So the inflammaging is a real story. So if I'm thinking about all of this in the context of multiple sclerosis, I'm thinking about, obviously, MS needs to be treated early on in the course of the disease, and we want to monitor and use biomarkers and really pay close attention and achieve success and get NEDA. But as an individual ages with MS, we have to be mindful of the fact that immunosenescence of the adaptive immune system and inflammaging of the innate immune system, it's real. And we have to be mindful of how we manage that and how we approach that. In terms of how you treat inflammaging, I think Tracy, she hit the nail, right there with the hammer, which is fitness, lower your BMI, nutrition, taking care of your human microbiome, hydration, and sleep hygiene. These clearly can have a huge impact on inflammaging. I've gone to these marathons where I've seen these 70-year-old guys out there that look like they weigh about 120 pounds. They look emaciated, but these are some of the more healthy people that are living to be really old because they're countering this whole notion of inflammaging. And they're shifting those cytokines back to where they're in equilibrium, like they were back when they were a child. So there's a lot to be said for everything that Tracy talked about. So in conclusion, I'm just going to wrap it up. I think we have a greater understanding of the pathogenesis of MS, and there's more to be learned. I mean, it's just, the story is evolving every day. Science and technology are bringing really more robust treatments, clinical biomarkers, things that help us, the neurologist, and you who are living with MS to get better results. We know that immunosenescence needs to be considered in older patients. It's a conversation that one needs to have with their neurologist. And we need to stay tuned because we know that anything that's going to happen is going to happen right here at MS Views and News. They're your source for up-to-date information. And I would have to say they really are your source for up-to-date information. And I really have appreciated our relationship. I think we've had a really great time. You've been a fantastic audience. And thank you so much.
Thank you. Thank you. Important question for those that are over 65, not relapsing but having new symptoms. What do you say to them?
I would say that the symptoms could be related to other things. I mean, not everything is MS. And I'm old enough to say that I have seen individuals with MS who have underlying malignancies, congestive heart failure, undiagnosed diabetes, peripheral neuropathy. I think that individual probably needs a good, thorough executive physical by their primary care physician. I think we probably would want to update the MRI with contrast, looking at any biomarkers. I think that we could look at Octave as a tool for helping us to understand the disease state. And I think that after we gather all that data, then I think we would have an answer for that individual now, which we wouldn't have had 5 years ago. But now I think we can answer those questions in with more certainty.
Is it possible to switch medications after 60? Will the insurance company allow this?
Yes.
Okay, thank you. All right, you're first.
What is the difference between fibromyalgia and MS? I mean,
Okay, so the question is, what is the difference between fibromyalgia and MS? So fibromyalgia would be considered a rheumatological diagnosis. So typically your rheumatologist would tell you that you have fibromyalgia, whereas multiple sclerosis is a very unique autoimmune disease of the central nervous system. Fibromyalgia is kind of a diagnosis of exclusion in an individual who has some degree of underlying autoimmunity. Maybe their SED rate is high, maybe they have a positive ANA, low titer, and they have a plethora of symptoms. They're typically like muscle aches, pain, joint pain, fatigability, insomnia, what have you. In the absence of rheumatoid arthritis, lupus, Sjogren's, sarcoidosis. So the rheumatologist would rule out everything else, and the diagnosis would then become a diagnosis of exclusion, which is called fibromyalgia in the rheumatological space, but totally different from multiple sclerosis. All right.
I got it.
Oh, how do you know if it's an MS symptom or something else? I'm new to MS and I don't know when I'm having an MS symptom, or is it something else?
I know, it's difficult, isn't it? We had that one slide that had the guy or the gal's arms out, and there's all that stuff, right? So in multiple sclerosis, the relapse part of this is easy. New or recurrence of something that lasts for more than 24 hours in the absence of a urinary tract infection that causes impairment of function. That's a relapse, okay? Everything else are these symptoms. And even in clients who are well controlled, the biology of this is well controlled, there's still numbness and tingling. There's still a bit of vertigo now and again. There's still this kind of cog fog. There's all this stuff. So I think we still don't have a total understanding of what's driving all of that. But I think anytime an individual who is living with MS develops a new symptom or becomes concerned about a pre-existing symptom, they need to get checked out. And I think that's the best advice. Yeah.
During the seasons, when the weather changes, I notice in the spring and in the fall, I have vertigo every spring and fall. So I'm like, is this MS? Because I have vertigo every time the seasons change.
I believe you. You know, I'm old enough now and I've lived long enough. I've seen so many patients living with MS. I've heard I've heard so much. And I believe what you're telling me is that is the absolute truth for you. And it begs the question, are you more susceptible to viral exposures in the spring and in the fall. When you get kind of in these kind of seasons where there's coughs and colds and what have you. Because we know that, and here again, there's environmental triggers, vitamin D deficiency, what have you. And you're going to have low vitamin D levels too in the early spring and as you go into the late fall and winter. So there's viral exposures, there's vitamin D, there's other things maybe that that are going on with you, but I believe that that's true.
So update. In June, we're going to be in Buffalo doing a program, and the topic for one of the speakers is environmental and seasonal changes with multiple
Great.
sclerosis and how it physically affects you.
You ought to make sure to be online for that program.
That's right.
And then they'll have the YouTube video that you can then follow them. That is an excellent team of docs up there at Buffalo. They're fantastic. Yep.
Thank you.
Just one simple question, Dr. Raza. The non-relapse secondary MS, this is the first I've heard of that.
Yeah, it's kind of, it's been around. I think perhaps over the last 10 years, we've just said secondary progressive MS. We just called everybody secondary progressive MS. So if you're not having relapses anymore, then, you're developing some kind of disability as it pertains, I would say, and Tracy would agree, mobility, we would call it secondary progressive MS. But now we're teasing out through biomarkers, through imaging with gadolinium-enhancing lesions, with some of these other serum biomarkers. There's a group of people that are progressing on the red line, but they're still having relapses. They're still having those bona fide, greater than 24-hour change in function relapses, but they're progressing. So we have deemed that group to be the active secondary progressive MS. And most of all of the disease-modifying therapies, including the high-efficacy therapies, they all have that as an indication. The insurance payers will say, yes, you can use these drugs if this person on the red line is still having relapses. But there's another group of people, Rashawn, that they just don't have relapses anymore. And they don't have primary progressive MS. They relapsed early in the course of their disease, but something about the biology of the disease changed, and they just don't relapse anymore. So maybe we're seeing less of an inflammatory response, maybe more of that microglial response with the secondary degenerative changes taking down the myelin and the axon, the wire that myelin is encompassing or surrounding. So it is a true category. And in the Hercules trial with the NIBs, the tolobrutinib, it was that cohort of patients that got the best response from the NIB. And we're also studying NIBs in primary progressive MS.
Yes, I would like to know, do they have a cure for MS, or are they working on a cure?
That's a great question. I
know?
appreciate the question so much. There's a really famous neurologist, scientist that lives in the UK, and he always says, it's Gavin Giovanni, and he always says, dare we say the cure word? He always says it. He thinks there's the potential for a cure if we can eradicate Epstein-Barr virus. I mean, just a question. Because if EBV, from what we know from this longitudinal Veterans Administration trial, we know that could be a primary driver of multiple sclerosis, then what about a vaccine to EBV? What about antiviral therapy? What about immune reconstitution? There's all kinds of things we can think about. But I would say we could probably use the word remission. I see patients that are in remission. But Dr. Gavin Giovanni said, do we dare say the word cure? I hope that we're going to get there, but nobody's talking about it just quite yet. Okay?
Dr. Reiser, you mentioned that a blood draw could create an activity score. Is that blood draw a substitute for an MRI?
No. It would be in addition to. I think that all of the biomarkers should be used collectively, but I would say, Rita, and your question is spot on, what if someone comes in for their 6-month follow-up and their MRI is stable, but they look at me and say, I'm not stable, I'm just telling you. And I say, well, let's check the octave too. And what if the score comes back at a 7 on a 0 to 10? Well, something's going on biologically. We just can't see it with the naked eye on the scans, even with the cells and the pearls and the central vein signs and the GAD. So now we have another tool to really help us to drill down on the biology of the disease. Yep.
Thank you.
Dr. Rouse, I got quite a few family members that has MS.
Mhm.
And at this point, what is the best medicine that you think that they can take?
Well, you
or
know,
should take?
it is interesting. We do see some families where there's a lot of members who have MS. This is a polygenetic situation. There's not one gene that drives MS. I mean, like things like if it's sex linked, like all the boys get it, or if it's autosomal dominant, half the kids get it, or if it's, autosomal recessive, 25%. MS is more complex, but I do see families where a lot of individuals have MS. But to your point, we are blessed to have over 20 MS disease-modifying therapies, biosimilars, generics, you name it. We are living in a time where we have lots of choices. So we try to really find what we think is the best choice for that particular individual, because no two people with MS are alike. Okay.
Okay. Thank you. I would like to ask a question. I had spoken to Dr. Reiser about 5, 6 years ago, and I told you about 30 years ago, about 30, 34 years ago, I had transverse myelitis, about 30 years ago, transverse myelitis. And they checked me, they did a spinal tap to be sure, that I had no lesions on the brain. Oh, so do you think that, like now, I heard you say you could get a UTI,
Mhm.
a UTI, but would that be a reoccurring from that transverse myelitis in my right side when I was younger?
So a common clinical presentation for NM multiple sclerosis can be transverse myelitis. So that's inflammation of the spinal cord. And when someone comes in with inflammation of the spinal cord, the transverse myelitis, we're obligated to kind of look at McDonald's criteria to determine, is this a one-off? Did you just have transverse myelitis? Or do you have multiple sclerosis based on the criteria? So assuming the brain MRI is normal, the optic nerve MRI is normal, the MRI of the spine just shows the one spot in the spinal cord, the spinal fluid shows no oligoclonal bands, then more than likely you had what we call clinically isolated syndrome. You had an attack. Demyelinating attack. Could it morph into MS? Well, the initial data seems to predict that it probably won't morph into MS based on criteria, right? But that's not to say that someone with a TM, a transverse myelitis, couldn't develop multiple sclerosis down the line. But the beauty of today, we have all these additional layers of biomarkers, that where the scientists and the neurologists and the clinicians say, you know what? You still got the TM, you're okay. Now, if you have any event, whether it's an optic neuritis, a TM, weakness, whatever, and you have a UTI, a urinary tract infection will make you feel like you're having a relapse. And once you treat the UTI, it'll go away. So that's the caveat.
Okay, doctor.
Yes.
We have a lot of questions online, and we have to run through all these in 15 minutes, okay?
Okay.
All right, you ready?
Yeah.
First one, short and sweet. Any good tips to overall reduction of inflammation?
In terms of, so the question is inflammation as it pertains to the pathology of MS, like the cytokines and all of the things that are inflammatory biomarkers. Well, it's important to be on a disease-modifying therapy. I think that's most neurologists that I work with would agree on that. The second would be to engage in those activities that Tracy was talking about to lower your BMI. There's data to suggest that if one can be less obese, they can have a less inflammatory immune system. So I would kind of lean in heavily to exercise, fitness, nutrition, maybe adhering to things like the Mediterranean or swank diet. I think sleep hygiene can help with inflammation. and certainly hydration. I think all of these other kind of, homeopathic interventions can help as well.
Okay, thank you. Next one is, do we really have a definitive evidence that taking large doses of vitamin D to get values of normal helps osteoporosis or multiple sclerosis?
I think there's sound evidence for osteoporosis. I think that's been proven. The story behind the vitamin D and MS is still, it kind of cuts both ways, because we see people who we optimize their vitamin D and they still relapse and they still have issues. But I think the consensus is that we probably should optimize it to the degree that we can. We don't want to overdose on vitamin D. It's a fat-soluble vitamin and it can cause downstream side effects. And I think if a parent has MS, it's probably wise to have the pediatrician check the children's vitamin D levels and to optimize those.
Thank you. Will this BTK address smoldering MS, PIRA, progression independent of relapse activity? I felt horrible and I feel horrible and had blood tests and MRIs and all were stable.
I think the answer to the question is we're moving into a new space in terms of how we really view progression in multiple sclerosis. I think it was kind of felt that like if the horse was out of the barn, there really wasn't anything we could do to reel it back in, unfortunately, other than homeopathic therapies and interventions. But I think we now have very sound scientific evidence that the microglial cells, perhaps, and other immune cells are involved in the progression, and the data from the Hercules trial, at least it's giving us a first read on the impact of NIBs in that progression or PIRA space. We have other NIB trials that are still going on. We're part of the fenebrutinib trials for both primary progressive and relapsing MS, so stay tuned.
Okay, thank you. Next, many of us have progression with increase in fatigue and decrease in cognitive function. These aren't measured by my neurologist and not part of the EDS score. So why then do docs still use EDS scores so much?
I'm sorry Tracy left because we just do not like the EDSS score. We do it because we have to in clinical trial. The expanded disability score is a score we use in clinical trial to measure how well or not so well a patient is doing with MS. And it's like 0, you're perfect. If you get to where you're having trouble maybe with balance and walking difficulties, maybe you're a 3. If you're using a single point cane, you're a 6. If you have a rolling walker, you're a 6.5, and so on and so forth. It is strictly, really, it's got some visual and some mild cognitive stuff, but it's really a mobility scale. It's very weighted on walking. But now we have something called the symbol digit modality, the SDMT, the symbol digit modality test, And that is a better metric of cognitive dysfunction, and we use that in the clinic. It's a quick tool. If your neurologist doesn't know about it, they can go online and take a quick test and get certified in it. But the SDMT is the best way to get after cognition.
Thank you. Next, is there anything known yet about the octave score to know if it'll change with age or other illnesses?
I think they're looking at this. I'm certainly looking at this in the clinic. And I'm starting, here again, this is just personal experience. I'm not reporting data. I'm just sharing with you that I'm seeing a cohort of people that are older that chose not to be on DMTs, disease-modifying therapies, whose their scores are really low. So there is something real to immunosenescence, but the people at Octave are continuing to look at these data sets. Once we get some, real-world data reported at a Congress, then we can come back and share that with you.
Thank you. Person writes, your presentation seems to imply to continue DMT therapy indefinitely, even after 60 years of age. What are the telling signs that it's time to stop the MS therapy?
There's a couple of papers that have been written here recently, and Stuart, you're well aware of those. Maybe you could post these papers. I can get those for you. But there's a group that's all in on maybe it's time to chill on the DMTs if you're taking maybe one of the first generation DMTs. Those are the the injectable therapies in particular. We don't see much of that as like we used to. But I think with the higher efficacy therapies, we have to be very mindful that there can be kind of a rebound effect in suddenly discontinuing a DMT. So I think that's where the conversation has to come into looking at the entire package with all the biomarkers that are available, imaging biomarkers, serum biomarkers, what have you, and then trying to make that decision together so that, we don't see any kind of rebound relapse.
Thank you. And I'm not a medical doctor, so whatever I say, don't listen to, but I've heard people say that for those that use original baseline therapies, if they never really worsened and they are now at 65, that maybe it is a good time to come off. But for those that needed to use the high efficacy medications, when is a good time? Most will say when you die is a good time to stop.
I would say that's probably consensus amongst the people that I hang out with, the MSologists in the centers.
Right.
Yep.
Okay, next, how often should gadolinium be used safely?
Okay, so there's an organization that oversees the use of gadolinium for patients who are living with MS, and they work with a consortium of MS. This is an international organization. And the recommendation is to use gadolinium at the time of diagnosis. Maybe if there's some mitigating reason to use it, like a relapse. But otherwise, for patients living with MS who are getting surveillance MRIs, it is perfectly safe and reasonable to do non-contrast MRIs because gadolinium could theoretically accumulate in the body over years and years and years. And the MSologist who is monitoring you, an individual living with MS, they know a lot about imaging, and they're able to understand the nuance of the cells and the pearls and the other things that are occurring as background noise without having to give the gadolinium.
Thank you. Next one is basically that if a person is aging with MS and they're doing well with symptoms, but yet heat intolerance is still pretty bad, how do they, will that ever get better?
Heat intolerance is a big problem for all individuals. I would say most individuals living with MS. I have a handful that have cold intolerance, but by and large, it's heat intolerance. Okay. And for heat intolerance, this is where the cooling vest comes in, and the icing and the cold showers and being mindful of humidity and turning the thermostat down and using the fans and so on and so forth. So it is a problem. There's not a drug that we can give you to make the heat intolerance go away.
Thank you. Next one. Next one was asked by many. Do clinical trials that enroll patients are there clinical trials that enroll patients over the age of 65 in this day?
No. It's
Not yet.
unfortunate, but the answer is no. So, in clinical trials, the statisticians have it designed to where they're trying to capture, that inflammatory phase of MS. So most of these trials are going to be between the ages of 18 and 55. Typically, we have a couple of trials that go into 60, but most are between the ages of 18 and 55.
Okay. I had a question to ask you about cognition, but I can't remember it.
Me too.
Thank you. Thank you. Next. I want to thank, there's a person online that I'm very glad to see that she's online, and she's still online, from New Zealand.
Wonderful.
It's already tomorrow in New Zealand, so
that's
way to
so
go, Wendy.
cool.
All right. Next question. Could you talk about the risk of malignancy with MS drugs?
There's a yin and a yang in the immune system. So we're trying to modulate the immune system, dampen down this inflammatory response, do all this stuff. We have to use drugs that induce immunosuppression. And in doing that, remember, we're kind of altering the balance, the cytokine balance and what have you. So there can be a slight uptick, with malignancies. Usually these aren't going to be like your big solid organ tumors. Typically you'll see basal cells, squamous cells, abnormal pap smears, what have you. I think a lot of this came out of the Mavenclad data because it wasn't really FDA approved here initially like it was in Europe. And then we collected another decade of, malignancy data. And as it turns out, it was overestimated in some of the trials. But we recommend if you have MS, you're a person living with MS, you should have an annual eye exam. You should have an annual skin exam. And you should have your mammogram if you're a female and your pap smear. And just don't forget to see your primary care doctor and do all of your general surveillance on an annual basis.
How do you feel about using a BTK inhibitor for somebody with smoldering MS?
I think that that might be the ideal candidate. I think with the Hercules data that's now been presented to the FDA on a fast track program, if it does get approved, I think you'll see MSologists reaching for the BTKI for that cohort.
Thank you. A person is asking, what's the difference between Zenovo and Ocrevus?
Okay, so both are, and there's a booth here if you need more data after the meeting. Okay, online. I'm sorry. Yeah. So they're both a monoclonal antibody called ocrelizumab. Ocrelizumab. So ocrelizumab is a monoclonal antibody directed at the CD20 on the lymphocyte, so it'd be classified as an anti-CD20. Ocrevus is the intravenous form of ocrelizumab. It's infused every 6 months. The only caveat is the first 2 doses are split in half. The Zenovo has been recently approved. It is a subcutaneous form of ocrelizumab given subcutaneously over 10 minutes every 6 months.
Thank you. All right. We have one more question, and then we're going to switch to our last speaker of the day. And the next question goes back to, it wasn't research, it was medications after 65. If a person does need to make a switch, do they go to a high efficacy medication or do they go to a lower efficacy medication?
So typically, if someone is over 65 and they've been on a very high efficacy medication and all the metrics look good in terms of imaging, relapse rate reduction, what have you, we probably would not just discontinue therapy, we would de-escalate therapy. So we probably come down to something that would be considered to be less immunosuppressive for that individual because of the immunosenescence that we talked about.
Excellent. Thank you. Everybody say thank you.
You're welcome. Thank y'all.
Awesome. Thank you so much.
You're welcome, my friend.
Thank you. Everybody have a great night. Ta-ta.